We're here with Dr. Caroline Coombs-Skiles, and so excited to be with you today. My name is Janae Gerard, and I'm the author of Off the Rack, and I'm also the creator of Beyond the Booby Trap. And Dr. Coombs-Skiles, she's a breast surgeon, so we're really excited to have you with us, and my whole group is very excited to ask you some questions.
Well, good. Thank you for having me.
Sure. Okay, so first off, some of the questions that we got revolve around lumpectomy versus mastectomy. So what are the pros and cons of a lumpectomy versus a mastectomy?
Well, if there can be a good thing about breast cancer is that patients have a choice, whether they want breast conservation surgery with a lumpectomy or if they want to go ahead and get a mastectomy. And with a mastectomy, you can kind of have the peace of mind that you're not going to have screening with mammograms for the rest of your life, although you will still need physical exams just to make sure there's no recurrences. Now on the con side, there's more concern over surgery time can be longer, and obviously recovery time can be longer for mastectomy since it is a bigger procedure. On the other hand, with lumpectomy, of course the advantage of that is that you get to keep your breast. However, women will need to get mammograms, diagnostic mammograms for the rest of their lives to be sure they don't have any in-breast recurrences. And along with a lumpectomy comes radiation therapy that they do need to undergo.
Okay, so is there a difference in reoccurrence when you're looking at lumpectomy versus mastectomy?
There's some important things to remember and to be sure you've obtained whenever you're having lumpectomy. First of all, you need to make sure that you have clear margins. That means when you take the portion of the breast that has the cancer in it and the pathologist looks at it under the microscope, you have to be sure that there's no margins on the periphery of the specimen that still have cancer in them. And if you do, then you may have to have another surgery, and that can be another drawback of a lumpectomy. So once you obtain clear margins, and obviously once you've undergone your full treatment of radiation therapy that comes along with radiation, the in-breast recurrence of lumpectomy is extremely low and very comparable to a mastectomy.
Okay, so when you're actually looking at the mass, the tumor, or the cancer itself, how do you actually locate correctly where it is in the breast when you're actually making decisions on what you're going to take out?
The breast is made up of lobules and ducts, and the breast tissue on the whole pretty much looks like fatty tissue. So sometimes if a cancer isn't palpable, meaning you can't feel it, it can be hard to find out where the cancer is during surgery. So there's things that we do to help with that. One is you can have what's called a needle localization, which is when the doctor puts what's a wire that goes through your skin and into your breast under local anesthesia, and the wire has a little point on it, a little arrow at the very end that kind of directs the surgeon to where the area of concern is and where the area that needs to be taken out. Also, if your cancer is visible on ultrasound, we can do ultrasound during the operation to help direct where the tumor is and what portion of the breast to take out.
So when you actually take the lumpectomy, or you do a lumpectomy, let's say, and there's still, why would there not be clear margins, as far as the removal, and then you look at the pathology looks at the slides and shows that there's still cancer left?
Well, the breast tissue all kind of looks the same, and cancer is not necessarily visible to the naked eye without a microscope. So when we're looking at it, you can't necessarily tell where the edge of the cancer is. I mean, you go into it knowing, like we talked about with the wire localization, where the cancer is, and you already know how big it is based on your mammogram and your ultrasound workup of the cancer. Mm-hmm. So you have a pretty good idea. So positive margins only occur about 20% of the time. But it's still a real statistic, and it still happens, and it's important that the patient knows that going into it, that they may have to have another surgery to obtain those clear margins.
Now, is there a certain size at which the cancer is to where you do not qualify for a lumpectomy?
Well, that's another consideration you need to take, is how big the cancer is versus how big the breast is. And if when you take out the cancer, there's such a high ratio that you're not going to be leaving much breast tissue, well then that person may be a better candidate for mastectomy. Another thing to consider is if a patient does have a large tumor and they really want to have breast conservation therapy, they can undergo neoadjuvant chemotherapy. And what that does is chemotherapy, it means chemotherapy before your surgery, and it can help shrink the tumor and potentially increase your possibility of getting a lumpectomy instead of a mastectomy.
Are there certain types of cancer where you just recommend, because they're more aggressive, to do a mastectomy versus a lumpectomy, and what would those be?
One cancer in particular that is more aggressive is called inflammatory cancer. And patients that have inflammatory cancer usually will end up getting a mastectomy. It's called inflammatory cancer because it involves what's called the dermal lymphatics, where the cancer is actually spread to the skin, and it looks like a hot, red, tender, infected breast. In reality, it's actually a cancer. So patients with inflammatory cancer do end up getting a mastectomy. Another kind of controversial area is something called Paget's disease. And what Paget's disease is, similar to inflammatory cancer, it appears on the patient's skin, is how it presents. And it can be kind of a dry, crusty lesion around the nipple areola complex. And that can sometimes require mastectomy because you do want to take out that portion of skin that's affected. You don't want to leave that skin in at all. And so you may end up having to get a mastectomy.
Now, when you go and do the lumpectomy, are you actually, or do you do the sentinel node dye injection when you do the lumpectomy?
Yes. There's two ways to help direct your surgeon to where the sentinel lymph node is. You can do a blue dye that's injected peritumorally, or just around the tumor, right before your surgery, after you're already asleep. And there's also a radio tracer that can be used, and that's injected in the radiology department before you go up for your surgery, also around the tumor. And we can use a special counter that makes a noise that can kind of direct us to where the sentinel node is in your axilla.
Okay, perfect. Well, thank you so much. I really appreciate you talking to my group, and I really
Thank you.
appreciate you bringing all this information to us.